Hello again everyone, this is Dr. Habib. Welcome back to my channel, and today we will be talking about community-acquired pneumonia, and hopefully by the end of this short lecture you'll have a better understanding of this disease and be able to manage it much better on the wards. So we will briefly discuss the pathophysiology of pneumonia, the clinical presentation, investigations. We'll also have a look at which organisms are responsible for causing community-acquired pneumonia, and finally the management and looking at a scoring system which helps you determine the severity of the disease. So let's start off by talking about the pathophysiology of pneumonia. This is an illustration of an alveolus, and as you can see, this is the capillary I'm labeling here, and this is the diffusion of oxygen into the red blood cells which we'll have in the capillary, and the outflow of carbon dioxide. So this is normal, but in a pneumonia the alveolus is going to be filled with something called an exudate. Okay, so this is an inflammatory soup of neutrophils, macrophages. Okay, so this is going to prevent any kind of diffusion of gas. And therefore you get low oxygen in the blood, which is called hypoxemia. You will see this manifest in terms of the patient's oxygen saturations and also on the arterial blood gas sample, the PaO2 levels less than 8. Okay, this is known as type 1 respiratory failure, and if the carbon dioxide is also raised, it's known as type 2 respiratory failure, seen in patients with chronic obstructive pulmonary disease. Okay, so in terms of the pathology, there's basically 4 steps we've got, and the first one is known as the stage of congestion. Then we have something called red hepatization. Followed by grey hepatization. And finally, the resolution phase. So in congestion, the pulmonary capillaries are going to dilate and serous fluid is going to exude out of the capillaries into the alveolus, which is why you have the obstruction and a barrier to diffusion over there. The patient's going to have a fever, they'll have a cough. So that's phase 1, and phase 2 is red hepatization. It's termed so because the lung literally looks like red liver at this stage, hence the term red hepatization. At this point, the affected lung lobe, be it on the right or the left side, is going to be more solid, and it's going to be full of red blood cells and strands of fibrin. And the patient's going to be hypoxic, and it is because of the red blood cells and the fibrin in it that sometimes patients with a pneumonia can also have hemoptysis. Moving on to grey hepatization, which is phase 3. This happens between days 4 to 8, and the lung still remains solid and starts to look like grey liver, hence the term grey hepatization. The alveolus at this point is also full of neutrophils, and the patient coughs up purulent sputum and continues to be out of breath. And finally, the resolution stage, which starts at around days 8 to 10. The macrophages in the blood are going to clear the inflammatory exudate, and the lung returns to its normal architecture. Let's have a look at some of the organisms which cause community-acquired pneumonia. The first one, the most important one to remember, is Streptococcus pneumoniae. This is the most common cause. This is also known as pneumococcal pneumonia. And then Haemophilus influenzae. If you have an elderly patient, you can consider this organism as one of the causes. According to UK figures, in up to 25% of the cases of pneumonia, we don't usually see an organism. This may be because the general practitioner has treated this in the community and the patient subsequently improved and the infection resolved, there wasn't much of a need to find out the organism in this case. And having a look at something called atypical organisms, of which there's quite a few. You've got Legionnaire's disease, you've got Mycoplasma pneumonia, chlamydia, and Q fever. So Legionella can cause pretty severe disease. It happens due to infected or warm water. You can always ask about foreign travel in your history. And it's also common amongst male smokers. And it could also have neurological and gastrointestinal manifestations. And it usually causes severe pneumonia with multi-system involvement. Mycoplasma pneumonia outbreaks occur in young people living in institutions. It can present with a prodromal headache and malaise. It can lead to hyponatremia. Immunological extrapulmonary manifestations can also occur, such as myocarditis, hemolytic anemia, thrombocytopenia, and neurological abnormalities. Chlamydia species also cause pneumonia. They can range from a mild illness to a more severe form of disease. It's spread by birds, especially parrots. And looking at Q fever caused by Coxiella burnetii, it's a zoonotic infection spread by animals via dust and unpasteurized milk. It presents as an acute flu-like illness, and chronic infection can have systemic involvement of the heart, bone, and eyes. The reason these are called atypical pneumonias is because they tend not to present with pulmonary manifestations such as cough, shortness of breath, and a fever, rather with more non-specific symptoms such as generally feeling unwell, gastrointestinal effects such as diarrhea. And having a look at Staphylococcus aureus, this is an important organism in hospital-acquired pneumonia, and it can also happen in people who have had influenza. Although studies have shown that Streptococcus is more common in people who have had the flu as opposed to Staph aureus, okay? So in terms of the symptoms, patients present in a typical pneumonia with a cough, shortness of breath, fevers, pleuritic chest pain. And on the next slide, let's have a look at the system used in the UK to grade the severity of disease. It's something called the Curb 65 score. It's recommended by the British Thoracic Society, and we'll have a look at the individual components of this score. C stands for confusion. U is for a value of urea greater than 7 millimoles per liter. R stands for respiratory rate if you've got a tachypnea greater than 30 per minute. B stands for blood pressure, a systolic of less than 90 millimeters of mercury, or a diastolic of less than 60. You score a point for all of this, and if your patient is equal to or greater than 65 years of age, you get another point, okay? So let's say if you have a score of 3 or more, that means you've got a severe pneumonia and need an inpatient stay and be treated with intravenous antibiotics. If you've got a score of 2 or more, then your pneumonia is also slightly more serious and you will need an inpatient stay again. For scores of 0 or 1, you probably are safe being treated in an outpatient setting with oral antibiotics. Let's have a look at the investigations for a pneumonia. So we'll start off by doing some blood work, followed by a chest x-ray, an arterial blood gas, cultures, antigen testing, and antibodies. I mean, this is only if the cause remains elusive. In terms of bloods, we can do a full blood count, renal function, CRP. So these are the three main ones to do. You can find out how high your white cells are, derangement of renal function indicating an AKI, one organ involvement as part of the whole sepsis pathway, and CRP tells you how raised the infection markers are. Chest X-ray will help you show a consolidation in any of the lung lobes. You will see something called air bronchograms, because air is now flowing in the larger airways as the alveolus is blocked off by exudate and pus, and the ventilation occurs in the larger airways. Okay. An arterial blood gas is typically done if the SpO2 is less than 92%. It can show you hypoxemia and can tell you whether it's a type 1 or type 2 respiratory failure. It will also show the pH levels and the lactate, and say if your patient isn't improving on ward-based care, then ABG is essential to present the patient for critical care physicians so that they can take over the care and provide pulmonary support. Sputum and blood cultures will also help you identify the organism. You can also send for a TB test via early morning sputum samples. Antigens, these are usually for Streptococcus and Legionella. Okay. Infected individuals excrete the antigen in the urine, and it binds to the antibodies, which is the rationale behind having them tested via an antigen test. And in some cases, like I've mentioned, if the diagnosis is still unclear, you can do a serology, but it usually takes about 7 to 10 days for this to come back, and it may not alter or influence your treatment after all. Let's have a look at the management of pneumonia. So let's say you have a patient who needs to be admitted onto the ward, but is not unwell enough to require critical care, so intravenous antibiotics on a ward-based setting. So you've done your history, physical exam, and requested the investigations. So, and if they're septic, you will commence them on intravenous normal saline, 0.9% saline, maybe 2 liters, depending on their body weight. Intravenous antibiotics. This is guided by your local hospital guidelines. When I was a junior doctor, I used to start them on intravenous augmentin. This is the trade name for coamoxiclav, 1.2 grams, 3 times a day, plus intravenous clarithromycin to cover for atypical organisms. That used to be 500 milligrams, twice a day. If they had any pleuritic chest pain, I used to prescribe them some analgesia. And oxygen. It depends on how badly hypoxic they are, but usually if they're acutely distressed, you can put them on high flow oxygen via a face mask. Okay. Bear in mind, in patients who have COPD, don't start them on high flow oxygen because that will just depress the respiratory drive. So a typical starting level would be an FiO2 of 24 to 28%, and then you can adjust this based on the response. So hopefully you will monitor the improvement of the patient. You will check their vital signs, their heart rate, the respiratory rate, the temperature, and the general clinical picture. You might see that their appetite comes back and they're feeling less and less fatigued. Then you can swap them to oral antibiotics. And say you have any results from microbiology indicating the organism that you thought wasn't quite the one causing pneumonia, then you can always taper or change your antibiotic therapy. as guided by the cultures and the sensitivities. Okay. And once the patient is well, you can consider discharge. They may need to go home on oral antibiotics again. And in terms of follow-up, it's quite crucial to repeat their chest x-ray in about 6 weeks' time. Now, why is that? So this may have been a consolidation, but if it's an elderly patient or they've been a heavy smoker, there's a chance that this obstruction of the lung causing the pneumonia may have happened due to an underlying neoplasm, squamous cell cancer of the lung. So 6 weeks is adequate time for this consolidation to settle. So you repeat the chest x-ray and see if it's clear and if the pneumonia has completely resolved. At this point, if they're well in your outpatient clinic, you can discharge them from your care. Okay. So I hope that gives you a good overview of the management of community-acquired pneumonia in a hospital. If you have any questions or concerns, please leave your comments below and I'll do my best to get back to you. Please like and subscribe to the channel. It'll be a great help. I'll do my best to improve the quality of the videos in the subsequent lectures. Take care. Bye-bye.